Welcome to Real Talk with the VaginaDocs, where we break down the P's of pelvic health: pooping, peeing, pregnancy, postpartum, prolapse, pain, pleasure, and physical activity. I'm Dr. Jocelyn Conley, pelvic floor physical therapist.
And I'm Dr. Jordan, chiropractor and functional medicine expert, and together, we're the VaginaDocs.
Let's dive in. Welcome back for the third time, Ursula the Doula.
Thank you. I'm so excited to be with you here again.
Your company was voted either top, what was it? The top doula agency in DC?
One of the top doula agencies in DC. This is an award that we have been awarded this award since 2017 when they started. And they determine who gets the award based on public reviews, public feedback, comments from other people, and obviously testimonials. And so it's completely independent. We have no control over it. And we got it again for 2024. So I'm excited to have that lineage continuing.
That is amazing. How proud of you are you of your agency, of your staff?
Yeah. We have a fantastic team. We continue to step outside of the normal bounds of what doula work is and try to find what it is that our clients need to make sure that they can get the services they want, to make sure that we're listening to them. And I think that's where all our Google reviews, our Yelp reviews, everything that's out there speaks to that dedication.
That's amazing.
Our team is just phenomenal.
And super exciting that now you're in Phoenix. So
yes. Spread the love.
Spread the love and the knowledge here. So interesting. Our conversation today, I did not do this on purpose, but social media is, it's a lot of work. And the person who helps us is in the middle of, it seems like she's always taking final exams, but we have not been able to meet up for our social media. So I have this amazing app, and anyone who has a company or is involved in social media, it's an app. I think it's AI generated, and it takes videos, full videos, like off of YouTube, and makes posts that from landscape into vertical. And I had taken a video that I had recently recorded and used that for my social media, and it was specifically on preparing for having a VBAC. And someone reached out and they're like, "What is a VBAC? Yeah. Tell me more about a VBAC." And not just from like, what does the VBAC stand for, but like overall, why is this something that we even have to discuss? Is this not a typical thing? So let's start there. And Ursula, just let's chat about, what is a VBAC? What does it even mean? Why is it such a big deal? And what do people need to know about it?
Okay, so let's start with the acronym VBAC. So VBAC stands for Vaginal Birth After Cesarean. And to further qualify, medicine is complicated, and because of that, there's a lot of shorthand that providers use. So instead of saying vaginal birth after cesarean, it's easier to say VBAC. We should also qualify just a couple of other phrases that are relating to this. So the first one is TOLAC, trial of labor after cesarean. And then we have RCS, or repeat cesarean section. So the reason why I'm going through this is there is a misnomer. And the misnomer is that you're trying for a VBAC. You're actually not trying for a VBAC. You're trying for a trial of labor after cesarean. Once you've had a baby vaginally, then you've received, open quotes, your VBAC. You don't try for a VBAC, or you could be trying for a VBAC, but you're not a VBAC mom or a VBAC dad or whatever until you've actually successfully had the vaginal birth after cesarean. So even as you're talking to providers, it's just much easier for us to speak in the shorthand, this lingo. And so they might say words like TOL, trial of labor, or IDOL, adduction of labor. It's nice to know that they're not dismissing you, rather they're just clarifying the goal, if that makes sense.
Absolutely. And you mentioned dismissing you. Why would someone feel that they were being dismissed in the first place?
I have two sons. My oldest son's currently in medical school. So I can tell you, not just from working in the medical field, but seeing what he's going through in medical school, the amount of study and dedication and learning that they're doing is far superior to what anyone can do on Dr. Google. I think we just have to be fair that doctors and midwives who've gone to school for obstetrics have a totally different understanding and working relationship with the knowledge than a layperson does, no matter how well educated they are. However, we all have Dr. Google. We can all just type into our server, hey, what happens X, Y, and Z? Give me the lowdown on labor. What do I need to know for a VBAC? And Dr. Google will generate responses based on how many clicks they have, not on the quality of the information. So a lot of what's happening out there is misinformation. And so when individuals, long story, short answer, when individuals go into the office and they say to their provider, this is what I want, they may have the best intentions in saying, this is what I desire, but they don't understand the nuances because the information where they got it from is not relevant. It's not evidence-based. It's not current. It's not based in reality. And I see it all the time, unfortunately.
So if someone would like to have a vaginal delivery after they've already had a cesarean delivery, do they need to go in there and say, I would like a trial of labor, or what's the acronym again?
Yeah,
Or,
they could just say, like,
or
we would like to try for a VBAC, or we're
okay.
interested in having a vaginal birth last time. Or they can say, we would like to have a trial of labor. Where it gets tricky is that there's some old studies that are being dismissed right now. One of them was called the ARRIVE study. And what they showed is that induction was medically relevant. It was helpful and it reduced poor outcomes in certain situations. Like I said, some of the studies now been dismissed, but that study became the norm, as have other studies. And those studies change the way providers practice, right? So if science is saying to you, the safest thing in this situation, based on the scoring system we have, is a repeat C-section, your provider's going to say, we recommend you have a repeat C-section. And they're going to say that in a position of authority because they have a governance behind them. They have a study behind them that shows that this is a relevant decision. That does not take into consideration the personal the parts. It doesn't take into that your head, your heart, your desires, what your healing was like, your home life. How many kids do you have at home? Does your partner have to go back to work immediately? It doesn't take into the rest of the human elephant. It only takes into consideration that medical element. As we all know, I know, nothing's a guarantee in this world. Even if the paperwork says this isn't a good idea, statistically, this isn't going to happen. I've seen it happen. And I've seen women have VBACs who were told they wouldn't be able to have them. And I have also seen individuals who we were swore they were going to have another great birth and have a C-section, or have a repeat C-section, or a situation unfolded that we were not expecting.
Before we go on to talking about the pros and cons of having a VBAC, what is the current cultural belief around vaginal births after a cesarean? I know early on in my training, we're both from the East, and out here in Arizona, it's a bit more, I would say, granola than out East. And I was discussing having I think this exactly with one of my friends who's a labor and delivery nurse. She's like, this was years ago. This was in 2019. She was like, our doctors will not do a vaginal birth after someone had had a cesarean because it is just too risky. So you mentioned the study. Has that been the belief? Has that taken hold culturally, or do people naturally think like, okay, I've had a cesarean, I'd really like to have a natural or a vaginal birth next?
Okay. So even prior to the ARRIVE study, and maybe that study wasn't a great example, the ARRIVE study had more to do with inductions, which we'll have to talk about when we talk about VBACs. But even prior to all those studies, in the 70s, in the 80s, and even in some places in the early 90s, once you had a scarred uterus, you always had a scarred uterus because they did not have necessarily the skill set or the knowledge or the understanding of how safe it was to have multiple incisions on the uterus. Okay. The American Congress of Obstetricians and Gynecologists now says that as long as you have only 2 scars on your uterus, you can still try for a VBAC. You can still have that trial of labor. But once you have 3 scars on your uterus, it is no longer recommended. And that is just because if you take a piece of paper and you cut it or you tear it and then you put a piece of tape over it and you tear it again, at some point the paper doesn't have that consistency. It can't hold up to the tension of labor. The same for the uterus. Okay. So guidelines have changed. In 2014, there was a huge conference out at the National Institute of Health in Bethesda, Maryland, where they changed their protocols on all of this. That does not mean that all the doctors go, yay, I want to do that. Some of them are like, no, I'm really comfortable practicing the way I am, and it's safer for me and it's safer for my clients, and we don't risk outcomes. And this is where my comfort level is, and my clients agree with that. There's also all this new research that has come out that says you can attempt a vaginal birth even if you have 2 scars on your uterus under certain protocols, under certain ideas, right? Like the baby can't be grossly big, there can't be other health issues, obvious complications. I think it changes by area. And I even saw this when I was on the East Coast. We would see it differently in DC than we would see it in Maryland or in Virginia. And the providers practice differently based on those state rules as well. So it's not a clear-cut answer. Probably the third piece of it is what is familiar and known. If you've had one C-section and you know what the recovery is like, maybe a 6-week recovery is less scary to you than 24 hours of labor and a 2-week recovery. Or maybe your partner has thoughts or beliefs or feelings on that as well. And that happens, right? My partner happens to be a C-section baby. All his siblings were also born by C-sections. My mother-in-law calls them her zipper babies because they zipped and unzipped her stomach. That's what he was raised with. That's what they were raised with. Almost all their children have been born by C-sections. The only ones that haven't been were mine, because I chose not to embrace that story. I chose not to believe that I had to do that because the rest of them did that. My story for me was strong. He was able to accept my story, but there's going to be partners or laboring individuals, women who have their own stories around what they want to embrace and what they don't want to embrace. And that has to be taken into consideration as well.
Interesting perspective, and interesting how these things can also capture the belief systems, not just in individuals, but bigger groups of individuals, families, and it can be generational. But that aside, who is an ideal candidate for a VBAC besides the 3 scar rule?
Okay.
You also mentioned health factors, so let's dive into that.
So the very first place I would go into, even before we go into health factors, is the pregnant couple's beliefs around what do they want to experience, what do they not want to experience, and where does risk exist for them. For some people, a cesarean is less risky than a vaginal birth. For other people, a vaginal birth is less risky than a cesarean. Part of that is health complications or health issues. Part of that is also belief system and what you've been told from the time you were a child. Okay. Mm-hmm. So if you were told from the time that you were a child that labor is miserable and your mother labored with you for 3 days and, they had to cut you out anyway, you may have been brought up with this story that your body is not capable and that you're going to need help. So why put yourself through the efforts of doing that? Okay. So,
and you're saying these things have to be discussed or at least recognized,
yes,
during pregnancy.
Most definitely. And I would go so far as to say, if you find that there's extreme beliefs, or if you had a traumatic first experience, or if you had a traumatic recovery, I would even recommend talk therapy and working through that prior to pregnancy, or at least at the early pregnancy, and not waiting to unpack all of that in labor.
What about even beforehand, before getting pregnant?
Totally.
I think this is something that should be discussed or worked on prior to even getting pregnant. But, some people get pregnant without planning on it. And
that's okay. And then you do the work. But if we know that there's a history of trauma, or if there's a story there, either parent or both, then we should do the due diligence of opening that book, exploring it, unpacking whatever needs to be unpacked, and then putting in place coping mechanisms or ways to deal with those challenges, right? So that could be having your mom show up postpartum and helping out, or having your mom not show up in postpartum and helping out. Maybe it's hiring an independent person, a professional doula, because they don't come with that family baggage or those preconceived notions or those stories. Therapists, it could be mental health, it could be PT, it could be that they had really bad pelvic floor tearing and they need to see someone for pelvic floor, chiropractic. So I'm sort of jumping the gun. First and foremost, I think the ideal candidate is somebody who both partners are interested in this. Okay. I think the next step would be a couple that is willing to put forth the time, the energy, and the money that it would take to address whatever those hiccups were. So if they had sciatica, working on the sciatica before and during the pregnancy so that they would be aligned when they went into labor. That would be working on their pelvic floor or the tearing they have or the concerns they have around tearing, learning how to push properly. That would also be, and we don't think about this, but it would be interviewing your providers and asking them the very simple questions of, one, I'd like to pursue a vaginal birth after cesarean. And the question two is, how will you help me to do that? And if they don't have an answer on how they're going to help you, then they're not going to support you as your pregnancy continues. And I see this a lot where they say, yeah, we're not going to worry about that right now. Let's just get through the first trimester. Okay, let's just work through the second trimester. Well, your baby's measuring big, your husband's got a big head, whatever it is. And then the noose gets tighter. And when you thought you had these options, those options are not there. So having the question of, this is what I'd like to do, and how are you going to help me? If they don't have a ready answer, oh, we're going to refer you. We have these resources. We don't believe in this. We're going to do that. That's huge.
Say again how early this conversation or this interview should take place. Is this before pregnancy, or is this like 8 weeks gestation? Because I think like some providers won't even see people that early.
Most providers don't see you until you're 8 or 10 weeks pregnant. Because all they can do before that is run a pregnancy test and say, yes, you're pregnant or not. There's no egg sac. There's nothing really to see or do before that. So most of them delay you. I would say that would be the latest to start having those conversations. So we're talking about vaginal births after cesareans. That means you already had a provider. Did you stay with your provider? Or did you look for a new provider? How did you look for that new provider? Did you ask your girlfriends? Did you ask your girlfriends who had C-sections or repeat C-sections? Or did you ask your girlfriends who did have vaginal births? Or did you type into the neighborhood listserv, hey, who loves their provider? Okay, what does that mean? What's their VBAC rate versus their C-section rate? I think this would be a great place to talk to doulas because they really know the providers, they know the hospitals, they know the practices to get some of that information. But in the end, you still have to interview them yourself. You still have to talk to them. You still have to do your due diligence. Nobody can do that for you but you.
This is totally going to start a rabbit hole. But first, red flags. Can we agree it's if you're dismissed on the question, like, oh, don't worry about that. So that's a red flag.
Yep.
And
Including,
then
let's not worry about that right now.
Yeah. And then, okay, second question. Scottsdale Shea Hospital, I've heard this over and over again from people who came into my office, has the highest C-section rate. Is that true? Do you know anything about that? And why do certain hospitals have the highest C-section rate? Is that just a hospital that has the most providers delivering there? Because I could see that being the case as well. But do hospital C-section rates have anything to do with the provider?
Yes and no. So yes,
Okay.
Scottsdale Shea has a reputation for having a higher C-section rate. Scottsdale Shea also just adopted a practice in there who one of their primary goals is to reduce the VBAC rate and to change the culture at Scottsdale. So we can talk about who that is offline, but it exists, okay? And so part of it is staffing of the hospital. Do they have enough staff? Part of it is the number of providers. A part of it is also the demographics of that hospital. So at Scottsdale Shea, you're not going to have as many minorities. You're not going to have different demographics. You're probably going to have an older patient population. And when you have an older patient population, you inherently have different risk factors, especially when it comes to pregnancy. The CDC tracks VBAC rates, and the CDC, interestingly enough, only tracks them for 20 and 30-year-olds. They don't track them for 40 and 50-year-olds. And part of that is because after 35, 38, there's just more health complications, which might increase your risk of a repeat C-section. But when we take those factors into effect, and I just looked this up before we got on the call today, in 2016, 2017, the VBAC rate was 12%. And in 2018, which was the last year they have studies, and the study was published in 2020, it had only gone up to 13.5%. So it's on the rise. So is our C-section rate. It's on the rise. But again, it's up to the individuals, it's up to the providers, it's up to health, dedication, desirability. All of those things factor into it, and it's not a clear-cut answer.
Hey listeners, if you're feeling frustrated with your sex life, whether it's due to pain, lack of pleasure, or just feeling disconnected from your body, we want you to know that you are not alone.
That's right. So many people struggle with these issues in silence, but it doesn't have to stay that way. We've created the Healing Intimacy program to help take you from pain to pleasure and restore confidence in your intimate life.
In this course, we dive deep into the physical, emotional, and even chemical factors that could be holding you back. And we'll give you the tools to transform your intimate experience.
If this resonates with you, head over to our website and join the waitlist. You'll be the first to know when the Healing Intimacy program launches, and you can take the first step toward a sex life that's not just pain-free, but pleasure-filled.
Visit www.VaginaDocs.com to sign up for the waitlist today. Your pleasure matters, and it's time to reclaim it. I have medical anxiety.
So do I.
I would consider myself very knowledgeable about health. I could have gone to medical school, and yet I dread talking to a lot of medical doctors. And I don't know if it's because, I'm doing a lot of healing work right now, and there's certainly adequacy issues and things that I've had to grow through. And so I'm sure that plays a role. But in general, I just feel dismissed 8 times out of 10 going to medical doctors. So, and I know I'm not alone. A lot of my patients they say they haven't gone to X physician in this amount of time because they feel like they're not heard. So what advice would you give to me if I had to do this interview with multiple providers potentially? How do I go about it if I have white coat syndrome?
Sure. So literally, I went through this 2 weeks ago. I walked into my endocrinologist's office. The medical assistant did my blood pressure and did all that stuff. And then the doc walked in and she goes, and I go, so before we get to the lab work, I want to show you my list of questions here. And I want to make sure that you understand that we leave time to answer all my questions. And she went, okay. And then she went into my blood work. And then, at the end of the visit, when I'm done with all my questions, she goes, so it sounds like you have a lot of questions, which is great. Why don't we have your next visit in 3 months instead of 6 months, which is what we normally would have done, so I can make sure that you're getting all your questions answered. That is a very easy technique. Walk in, say, here are my questions. And then when you feel flustered, you literally can read the questions off your phone. So you're looking at your phone versus looking at them. I find that works beautifully. Another technique, kind of similar, that I've worked with some parents, I have had clients with a history of abuse, or they had issues previously with the anesthesiologist or the way they were treated. And so if they have a problem advocating for themselves, we have them write it all out on a letter form and put it in an envelope. And when they leave their appointment, they hand this to the doctor and they go, these are all the things that I didn't feel comfortable speaking to you in person about, but I need them in my chart.
What a great idea.
And so that was an easy way. And so the next time that you go in, they can say to you, okay, we've read through this. We've put it in your chart. We've notified anesthesia. We've notified whoever. We would like to take these actions. We'd like you to meet with anesthesia ahead of time. We would like to make sure that you meet with NICU ahead of time, et cetera. Or would you like to discuss this further? And there's no judgment because they don't feel like they're being put on exposed, right? The third one is if they have a doula, and I have had clients who don't want to tell the provider that they have a history of abuse. But in our meetings, I say to them, do I have permission to share this with your team if it becomes medically relevant in labor? I will do it outside of the room. We don't have to do it in front of you. You don't have to feel shamed or judged or anything. And they go, yes. And so and I will just follow the doc out into the hallway or the nurse, or I'll just say, hey, can we talk outside? And I just open up my chart and I go, I have permission from the patient to show this to you. And I have them read it right out of their intake form. And they go, wow, that's great information. Like, glad we have that now. Now we can dance with that. We can move with that, where we wouldn't have had it prior to that.
Great suggestions. Sounds like many of us need to think about doing work on and thinking about this much earlier on than one would think. These are things, Ursula, this is why I bring you on the show. We're talking about things that no one's talking about in the medical community, or not many people are talking about. But these things have such an impact on your experience and how much stress that you're holding during your pregnancy, which undoubtedly affects your health
It
and
does.
therefore potential.
And you just have to find a way to communicate. And if it's something that's emotional or volatile for you, it's harder to communicate. Or if it's something that's complicated. I have a complicated medical history. I have a 1-page medical history of all my surgeries and diagnoses and whatever. And whenever I walk into a new doctor's office or I have to go in, like I had to go in for my parathyroid surgery, I brought a copy in. I gave it to the anesthesiologist. He opened it up. He goes, this is the best thing I've seen in a year. Like, you're obviously in the medical field because you knew to bring this in. Like, you just saved me all this time. I can scan it. I can read it. I know what questions to ask you. We can do that. It could be part of what we all do to help advocate for ourselves.
Absolutely. So back on track. So pros and cons of a VBAC.
Okay, so there are a lot of pros, and I want to be very clear and make sure that everybody understands that C-sections can be life-saving. I am not against C-sections for life-saving measures, or I'm not against C-sections to prevent mental trauma. And there are clients that I've worked with in the past that have PTSD or whatever, and a C-section was the safest option for them. And I'm so happy it's available for those individuals. But for the vast majority of us who are able-bodied, able-minded, we can have our babies vaginally. And the reason why I can say that's so clear, Jocelyn, are you a product of a vaginal birth?
I am.
So your mother had a vaginal birth, her grandmother had a vaginal birth, her grandmother had a vaginal birth. And I know that because otherwise you wouldn't be here, because they would have died, because C-section didn't exist in a hospital setting until the 1940s. So that means you have this lineage, thousands of years of lineage saying your body is capable of doing this. Why is it since the 1940s that we're no longer capable? Separate subject. C-sections save lives. Okay. For some people, it reduces birth injury. So if we have a really large baby, or we have a baby that's in there in a poor position, it can actually prevent injury, broken shoulder, a clavicle, dislocated shoulder, dislocated hip, or injury to the mom. So an incision can be the safer option in that kind of an option. For some individuals who have extreme pelvic floor issues, it can actually help to minimize more pelvic floor trauma. I have had clients who've had 4th-degree tears with their first baby and have no tears with their second baby, 10-pound babies both times. So that's not a guarantee. But again, if we're psychologically and emotionally concerned about furthering our pelvic floor trauma, a C-section could be a great option for those individuals. And then, of course, if we have 3 scars or more on the uterus, obviously those are reasons. There are also benefits for a vaginal birth, and there's benefits and risks for the mother and the baby. Where would you like to go next?
Let's talk mom.
Okay. So the risks for the pregnant person is that this is major abdominal surgery, and major abdominal surgery takes on average 6 to 8 weeks to recover. And 6 to 8 weeks, that may mean 6 to 8 weeks of painkillers. That might mean 6 to 8 weeks of not feeling normal, minimum of 2 weeks of not being able to drive your own car, relying on other people, not being able to carry the baby up and down the stairs. There's increased blood loss in a cesarean versus a vaginal birth. Have to take that into consideration. Sometimes when an incision is made, there is a possibility of nicking an organ. Usually your bladder is the one that's most commonly nicked, and then that can be repaired if need be. Obviously, because we're cutting into the tissue, there's a risk of an infection, and the longer the body is open, the abdomen is open, that infection rate goes up. So the rule of thumb in most cases is to try to keep the C-sections to an hour or less whenever possible, because of that risk. Postpartum, there's an additional risk of blood clots in the legs and blood clots in the lungs. Adhesions or bands of scar tissue is another possible complication, and that then has subsequent complications from there. And I think those are probably the big ones for the laboring or the person who had the C-section.
Now, baby.
So babies that are born by C-section are more likely to have respiratory distress or compromise, so problems breathing. And it appears that's because when babies come through the vagina, they basically get squeezed, or they get what we call a fetal Heimlich maneuver that helps to clear out those airways. And when they're born by C-section, we have to suction that out for them. Sometimes the baby can have small marks on their skin from the instruments that are used at delivery, just like we can nick an organ. In all my years of practice, I've only had one baby nicked. It was a true emergency, and the baby was born within 4 minutes. And there was a tiny little mark on the baby's, forehead that was going to heal beautifully. There's also some studies that are showing that babies that are born by C-section and not had a chance to labor first are at greater risk of type 2 diabetes, obesity, breathing problems. They're more likely to have surgeries in the future, asthma, etc.
So risk for mom, risk for baby. Anything else that would make a person either a better candidate or not? Like, is there certain health issues besides birth weight, number of scars on the uterus? Like, is someone who has autoimmune conditions just as safe to have a VBAC, or is that?
Yeah, interestingly enough, a lot of autoimmune issues seem to be suppressed when you're pregnant, and then they come back postpartum. So a lot of people who have autoimmune, celiac, lupus, things like that, they actually love being pregnant because their infections are suppressed. What I'm really talking about is more of type 1 diabetes or gestational diabetes and the implications of a very large baby or a very small baby. We're concerned about making sure that the placenta and the cord and the uterus, everything is structurally sound enough for delivery, that it's not separating prematurely or doing something weird. We're also concerned about babies that are in a position that can come out vaginally without too much trauma to the individual as well as the baby. So for example, a baby that's in a horizontal lie, transverse lie, they can't come through vaginally. I've only heard of one case ever, and it was a teeny tiny baby that actually was able to rotate last minute in the pelvis. Other than that, they physically cannot come through. So we would, if we tried to induce those or allow those moms and those babies to deliver, we would have lost one or both. If we have a baby that is being born in a face presentation where their neck is fully extended and their face is trying to come out first, that's a very dangerous position. Most babies that are in what we call military or boxer positions have a difficult slim to none or a forehead presentation. But that's where working with body workers and dealing with your mechanical issues or your fears or your concerns can help to make for a better environment for a birth comes in. Other things, preeclampsia, which is really big right now. We're seeing a lot of that. Health issues for mom or baby. Those are kind of like the big ones.
I would expect there would be more, and it just sounds like mainly baby size, beliefs,
Position of the baby.
position, and oh gosh, I would.
Fear.
It is, yeah, the fear is huge, but I would not recommend people challenging breech. I mean, if you want to try to get the baby flipped earlier I don't like the medical route. I forget what it's called, aversion.
TV. Mm-hmm.
But I mean,
Jocelyn, in all fairness, I have been at some beautiful ECVs. I was actually at an ECV at GW where we flipped twins using a German technique, and it worked beautifully. I've seen ECVs be very gentle, and if they're not gentle, the baby usually doesn't turn. Once we start applying too much pressure, it's just not meant to be. And also, just to be fair to you, I've also been at many, many breech births, and they've all been perfect. However, you need to have the right team. And if you don't have the right team, you have to be prepared for that not to be a safe option. And then the best option is a C-section. So GW, same hospital I was just talking about, they have doctors, midwives, and nurses that are specifically trained in breech birth, and they were doing it for a while, and they've stopped because of staffing issues and coverage and education.
mm-hmm.
So
I'm glad you brought that up, because staffing and experience does make a difference. Like, the ECVs shouldn't be painful and aggressive.
Correct.
And so when I hear that,
and the same is true,
and
vacuum or forceps. If your provider is not skilled with forceps, and we're at that point, you're probably safer having a C-section, and there's going to be less trauma to you or your baby than attempting a forceps delivery. But if your provider is skilled with forceps, having a forceps delivery and having a vaginal birth, the benefits of that far outweigh the risks. Shorter recovery time, baby coming through the vagina, having had a vaginal birth, better recovery, the baby gets squeezed coming through the birth canal, the positivity of I had my VBAC or I had that vaginal delivery versus a repeat C-section that you didn't want. I'm not saying it's for everybody, but with the right providers, and you have to find them, with the right providers, breech birth, C-sections, inductions are options.
That's a great segue into my next question. When someone is interested in having a VBAC, how do they find the right providers, or what suggestions? You already said interview them, but like who should be part of the team?
Mm-hmm.
And what are some key things that an individual should be looking for?
So if we're looking for a doctor or a midwife, the questions are, where do you deliver? Did the hospital have any restrictions around trials of labor or having a VBAC? What is your experience? How are you going to help me to do that? Right? Those kinds of questions. And then the other question I would also add into that is, what other providers do you recommend I work with? Because that will also help you to open that door to understand how well versed they are in alternative techniques or different types of medical management, right? Like pelvic floor physical therapists, chiropractors, massage therapists. I mean, there's a million applicable things here, doulas. So I think that's the first. And if they have people to refer you to, then I would talk to those people as well. But I would also be looking at making sure you have at least one body worker on your team. And I don't mean a massage therapist. I mean therapist, a chiropractor, role for somebody who does some sort of biomechanic work. And then I would make sure that I had a support network of peers that are going to support me on this journey. I was able to talk to my mom about wanting to have a vaginal birth. My mom had vaginal births, all different types, but she had vaginal births. I could not talk to my mother-in-law about my desire to have a vaginal birth because she had 4 zipper babies. So having friends who can listen to you or friends that have experiences that they can share, as well as professionals. So there's groups out there, VBAC Facts, the ICANN, International Cesarean Awareness Network. There are parenting groups. There are places where you can find peers going through or people who have gone through the situation that you went. And those are the people you want to surround yourself with, as long as it's positive.
Great final statement on that, because some of those support groups are not the most positive.
They can be.
But
it depends
there's
on
many
what
great ones out there.
Yeah.
Mm-hmm,
And
mm-hmm.
you have to find your tribe. You have to find your village. You have to pick and choose. And if you can find that doula, or if you can find that one person to start with. So even if they find this podcast and they say, okay, I'm in Phoenix, I'm going to work with Jocelyn. And then Jocelyn, you can say, okay, this is outside of my scope, but here's a practitioner who can help you with that. And then here's this, and here's a network. And then, here are my top doulas. And here, I don't know the providers, but they do. And then people can build their village. They can create a cocoon around themselves like that.
Okay, so finding the right provider team is of high importance. Now, What are other things that people can do? And we kind of talked about this, but what can people do to make sure that they're setting themselves up for the best chance of a successful VBAC?
So when I teach my childbirth classes, I talk about a 4-legged stool as the foundations. So for me, and this doesn't matter if you first pregnancy, third, fourth, the foundation is the same. So one leg is nutrition. And obviously when we eat a good diet, when we eat the appropriate things, we can grow an appropriately sized baby and keep our health and their health stable. 2 is good body mechanics, the way we move on our daily lives, the way we sit, the way we move. 3 is exercise. We have to exercise for the muscles that we're going to use in labor, but we also need to exercise to build endurance for labor. And we also need to exercise for mental health. And then the 4th leg would be stress reduction. So that's everything from sleep to breath work to your community, your partner, your support at home. So if you can have those 4 things, then you build out from there and you go, okay, now I have my OB, my midwife. Okay, now I have my physical therapist. Okay, now I'm picking an out of hospital childbirth class so that I can learn what my real options are and what I can actually ask for versus what the hospital is going to tell me I can do. Okay, now I've got a doula, et cetera, et cetera, et cetera. And how big that circle needs to be depends on each individual and their desire.
Yeah, but you can't, if someone absolutely hates exercise or is completely thrives off of just total chaos and stress, can't necessarily force them to do the things, but
Yes.
solid four-legged stool. I love that you not only say body mechanic or exercise, but you say body mechanics. That is just something that I teach this core reconnect class. And I can't tell you how many times I hear this, not only just with the class, but with my patients are like, I've seen multiple PTs or different providers and no one has taught me how to move the way that you've taught me. Like they just give me these exercises and I'm like, you could look like one exercise could look the same across 20 people and be completely different in what they're actually like targeting based on their mechanics. And, all the exercise in the world don't matter.
There's that piece of it. But also if we wear high heels, we're going to have a pelvic.
Sure.
If we always
Right.
carry our backpack on one side or our toddler on one hip, we're going to be asymmetrical. So it doesn't matter how many
Sleeping on this.
exercises somebody gives you, if they don't talk to you about your day-to-day life or see how you work or talk about and ask questions like, how do you lift things? How do you carry your toddler? People think I'm crazy. I go, no, your toddler should be sitting on your belly, square in the front, or they should be on your back. They should not be on your hip. Are they going to squish the baby? I go, no. But again, we need to keep you symmetrical and the kid needs to stay symmetrical too.
The one that I love, but isn't as big of a problem during pregnancy, it's sleeping prone, like face down with one hip up, like twisted. And I'm like, I can't fix your back pain if we can't improve some of this sleeping. You're literally laying there for 6 hours at least. Anyways, so body mechanics throughout the day are just as important.
And at night, right? That whole thing.
What about people with going into this pregnancy that have, whether this is their second pregnancy, third? I've had people that I've worked with, this is their third or fourth, their diastasis recti is substantial. I know what I do, and I've worked with doulas. I love the doulas who are open to working with me and hearing what I see and my knowledge. And then, because I'm not in the birth, what happens? What do you see in individuals who do have a significant diastasis?
So if they don't know they have diastasis, I usually find that it gets worse. I also find that their babies are more likely to be breech or malpositioned just because they're sort of passing through the abdominal separation and sitting outside of the abdominal cavity outside of the pelvis. I find that they're not always great pushers. We have to be very careful with how we push and under what positions and different ways. I like to use KT tape in labor to help to hold that together or to support it through pregnancy. There's belly binders that can help with that as well. And then, of course, there's the recovery process. And if you have a diastasis and then have a C-section on top of it, the recovery is going to be that much harder, that much more delayed. It's going to be harder to get back into it. The connection between breath and core, I think, is the whole basis of that, and how disconnected we are with how we breathe during the day, how we breathe at night, how we breathe when we exercise. And I was just watching some gym videos, watching individuals in the gym breathing and lifting and how they don't do that properly and how you can see their alignment and their weight. It just compounds.
I go to a CrossFit gym and it's just the way that breath is just taught across the board is just it's maddening. And it's interesting. Like when I get to work with professional athletes, whether it be women or men or either, no one is breathing optimally. So it doesn't matter what level of athlete or what level of mover you are. Breathing is so much taken for granted, and it is so impactful. If you breathe the right way, everything typically just falls into place. You don't really have to think about bracing your core super, super hard or anything like that. But do you see when people are pushing and they have diastasis and then that's not supported, like the belly bulges out?
Sure.
Yeah, I figured
Unfortunately,
that's what it would look like.
Yeah.
Have you ever used a rebozo?
So rebozo would be another way of just sort of binding the abdomen together. Some providers don't like to see the abdomen bound like that during pushing because it can impact them hearing the baby or feeling the belly. KT tape makes it a little bit more approachable for them. The rebozo is a fantastic tool in labor to get that baby from outside of the pelvic area back into the pelvis and supporting it. Use it less during pushing just because providers are not as friendly with it during pushing.
Makes sense. Based on what you see, any recommendations that you would make for individuals with diastasis that are already pregnant? Besides, I mean, my recommendation is see someone like me, but
So
I'm biased.
down, I would automatically say, let's start working with a pelvic floor PT or a PT specializing in diastasis so that we can prevent it from getting worse. And again, don't go hop on Amazon and buy any belly binder because there's different types of binders depending on what your situation is and where it's at. So work with a therapist for that. And a binder oftentimes can make things worse in the long run, especially if it's used inappropriately. So caution there, work with a pelvic floor physical therapist or a diastasis therapist, consider a binder or a rebozo or a KT tape. I would actually bring your partner into a visit so that the therapist can teach your partner how to do the KT tape or the proper way to put the binder on or the rebozo on. Involve the partner, make sure there's another set of eyes and ears. I would also not be afraid of switching providers. So if you start with one physical therapist and they're not the right match for you, don't be afraid of switching and finding another one.
Seriously, like it's best for the patient and it's best for the provider.
Yeah.
And no one's feelings should get hurt by
No,
any
and
means.
everyone, like, even though I have 25 years of experience and I've been at 1,500 births, that doesn't mean that I am the right doula for you, Jocelyn, right? And that's okay. We just have to find the right person for you.
So we've talked about quite a bit. We talked about what is a VBAC, what are the pros and cons of a VBAC, what are some considerations before even considering it,
Yep.
how to find a provider team, because that's super important. And then we just threw in there diastasis and the importance of being aware of it.
Which shouldn't seem like something abnormal because we do see diastasis with people who have C-sections or people who are considering a VBAC or a repeat C-section. The diastasis, the DR, could be the whole reason why labor didn't progress in the first place.
I'm going to throw in there that I would suggest instead of waiting till you're done having kids, get the rehab after each kid.
No
It
question.
will life-changing. If individuals listening to this podcast have questions, what's the best way they could reach out to you, Ursula?
Fantastic. There's a contact form on our website, which is birthyoudesire.com, or if they email contact@birthyoudesire.com, I will be answering those. I do offer free 20-minute consults to people. We do longer consults. We have birth doulas, postpartum doulas classes. I'm the educator for the classes. We have a slew of things to help you to figure out what's the right choice for you and to get the birth that you really are desiring.
And if you have questions for me, you can reach out through my website as well at VaginaDocs.com or on social media. We have contact forms. If you have questions, don't wait to get them answered. Ask them early. And then the question that I've asked you multiple times, Ursula, is what advice would you give to another individual to empower them in their pelvic health?
I think the first question I would always ask myself or somebody else is, what are your goals short term? And then what are your long term goals? And then ask them how hard they want to work on those goals. The short term goal might be, I just need to get this baby out of my body. The long term goal might be, I want to fit back in my jeans again, or I don't want to have a tear, or, I'm going to have 6 more kids, or whatever it might be. And the answers that we give you for your short-term goal might be very different than your long-term goal. And I think if we can look further out than what's right in front of us, we might make different choices in care.
Great advice. Thank you again for coming back onto the show, Ursula. You are just a wealth of information. Always love getting to chat with you. If you find this information helpful, don't forget to subscribe. And if there is any information that you would like to hear about in the future, reach out through our email, support@VaginaDocs.com. Until next time, Thank you so much for listening. Until next time on Real Talk with the VaginaDocs.